Past question will have 10 marks. And if there is a question where there are two components and one component the team answers and the second component goes to the next team, they will get half of that, so 5 marks, right? There are two people keeping tally of the marks, right? And you have 30 seconds to respond to each question. And when the question is passed, you will have 10 seconds, right? Uh, the first 3 rounds will start from team A. So who is team A? Okay, so from here it will proceed in A to F, and from the 4th rounds onwards, the second half will start from F and proceed in the opposite direction. There are no negative marks, and I hope we will not have to go into the tiebreaker session. If we go into the tiebreaker session, we will have rapid fire sessions where you will get 10 seconds to answer, quick sequence, right? And there will be open house questions in between to keep the audience engaged. Audience also will get 30 seconds to answer each. Before we actually start the rounds, I would like to thank the ISNSC, the Secretary of ISN Southern Chapter, Dr. Sribhushan Raju, and the Organizing Secretary, Dr. Manjusha, and the Scientific Committee for asking me to do the quiz, even though I think I'll be cursing myself for taking on the responsibility, but thank you for asking me to do the quiz. It was not easy doing that, so I had to take help of my extended team. Can you have the displays, please? I took the help of some of my friends, Dr. Karthikeyan, Assistant Professor in AIMS, Bhubaneswar. He helped with some inputs on the theory questions, as well as my own residents, Dr. Piyush, Dr. Rama, and Dr. Vidya, and our alumni, Dr. Shankar, Dr. Dhanin, Dr. Jaswant, Naveen, and Shravan, who are all here. Thank you, everyone. So we will go on to the rounds. So any questions before we start? Anybody has any questions? All right. Fine. So this first question will be to team A. So the slides will show, there should not be any confusion. You can read at the top. I have written which round, which question, and which team is supposed to answer. So it is customary to keep some history questions, even though I am not a fan of history. But I have kept one round with some questions with related to history. The first round will have, it will not have any text. It will show an image and a person, right? An image and a person. You have to recognize what is the image. You may have to look there because here the screen I see is a little small. You may have to turn around. So you have to recognize what is the image and who described or who discovered that, and you have to tell that person's name, right? That is the first round, right? Okay, all right. So we'll go on to the first question. I hope you are keeping time. Thank you. So this is the first question.
Is that good? Is that good pasture, sir?
No. Team B. See, you have to see what is the image showing.
A fistula.
Okay, all right.
Breciosemina.
Okay, so you will get half of that. So who developed the first AV fistula is the question. It's not about, okay, first AV fistula was done by Dr. Appel, right? So it is a past question. They answered only half of it. So they will get 5. Okay, so I hope the question is clear. Now again you will see an image, a person, right? You have to recognize what the image is showing and then tell who is the, right? So
Douglas.
No, sorry. Next, team C.
Sir, how to measure KT by V? So we have to use the blood samples pre-dialysis and after.
No, no, see, I told you, you have to identify and name the person. The answer is the naming the person. Okay. Next,
Deals with KTBB, which is deals with the adequacy of hemodialysis.
yeah. Name the people. That is the question. You have to name the person. Time is up.
Ronco.
No.
No.
Okay.
Sir, I have, sir. Sergeant and Ghosh.
But you won't get any marks for that. Okay,
Get
so you are
answers.
supposed to get. Okay,
We are
all right,
supposed to
fine.
answers.
Okay, fine. Okay, so you're supposed to come here. Sorry about that. They will get the pass mark. I'm sorry. They scored, no? The team A is supposed to get. Okay, all right. So team C. Team D.
Pass.
Hoffman. Discovered ACE
No, Hoffman means what? What was the discovery?
ACE inhibitors.
No, name is wrong. All right. Right, he discovered ACE inhibitors in 1974. We'll go to next team D. This round is problematic, so don't get upset with that. Okay, team D, right?
Aquaporin channel discovered by Peter Agre.
All right, okay, good. Somebody is getting easy questions. So, all right, so we'll go to the next. They will get 10 marks, 20 marks, yeah. So, next question is to team 5, team E. You are ready, right? You have to tell the full name of this person.
Stewart. Strong
That-
iron effect.
Okay, I am asking you to tell the full name because otherwise the name everybody knows. What is his full name? Because if you see the graph, you will know the name of the person. What is his full name? What is the first name?
Strong.
Your time is up. F.
Haggard Stewart.
Louder.
Haggard.
No, sorry. B. Next. You have completed, right? We have come to the end of the. Right, okay. His name is Peter Stewart. Right, he has 4 names, but then you're supposed to name the first name. Okay, all right, so leave that. We'll go to the last question of this round. Team F.
Oxygen sensing pathway in hypoxia inducible factor.
Name the person.
I'm-
Your time is up, sorry. Pass. B. C. D.
Discovery of prolyl hydroxylase inhibitors by Radcliffe.
All right, okay. So it is Peter Radcliffe who got the Nobel Prize recently. So fine. So that brings us to the end of the first round. I have an image for the audience. I am sure all of you know what image is, but I want you to name everyone in the image, right? Chako sir is not allowed to answer. We can start from that end. This I'm sure all of us would have seen. Timer is running, right? This question is to the audience. The clue is that this is the CMC team who did the first kidney transplant. Right, so Dr. Mohan Rao, Dr. Johnny, in that order from here. Dr. Martin, Dr. Bhatt, and the nurse and the patient. All right, audience, no marks for audience. Okay, so we'll go on to the next round. So this, I promise you, will not be eccentric round like the first one. So we'll start with the team A. This is the second round, question 1. Right. B, C, A, B, C, D. Shall we start? So, a 26-year-old lady with recurrent urinary tract infection is admitted with acute pyelonephritis. Urine culture is showing E. coli. Kidney function is normal. She is on IV antibiotics. 10 days later, she develops alkalosis, hypomagnesemia, hypocalcemia with normal blood pressure. Which antibiotic was she likely getting, and what is the mechanism involved?
Sir, aminoglycosides, sir, causing proximal tubular dysfunction.
Mechanism.
Sir, aminoglycosides
You are
binds,
correct. It is aminoglycoside.
binds by megalin receptors and it get endosized into the lysosomes and it causes lysosome rupture, causing proximal
All right. So
tubular
second
dysfunction.
half, can somebody else next team try?
Oh,
Your time is up, right? Next team C. D.
Toxicity.
There is a molecular mechanism involved, so that's what is being asked. Louder, louder. Can't hear you. Sodium. You can say without your mic also. Anyway, your time is up now.
By causing pores in the proximal tubular cell.
Not exactly. That's not what the intended answer is. You have to give the intended answer of the quiz master, right? Sorry about that. You may be right, but then last F.
megalin tubulin complex.
Okay, let's look at the answer. So this is basically Bartter syndrome induced by aminoglycosides. So this actually gentamicin, for example, is supposed to activate the extracellular calcium sensing receptor, and there you are actually, it's supposed to be that you can use calcium mimetic to treat this also, right? I'm not telling you are wrong, but then that is what not the intended answer is. So you get half the marks for the first half, right? Okay, all right. So we'll go on to the next question. So round 2, question 2, team B. 42-year-old lady, CKD stage 4, depressive disease, started on fluoxetine by her psychiatrist. 2 weeks later, she came with altered sensorium and seizures. Her renal function is stable and her BP is well controlled. What is the likely cause for altered sensorium and seizures?
SADH, hyponatremia.
Okay, all right. So SSRIs are known to produce hyponatremia, and that is by SIADH. Good. So they get full mark. Team B. We'll go on to the next question. Question number 3. Team C. 55-year-old man, multiple myeloma, quadriparesis, admitted with quadriparesis. MRI brain, spinal cord is normal. Neurological examination is showing muscle weakness, absent DTR, no UMN features. Medications is on treatment for myeloma is dexamethasone, thalidomide. BP and pulse rate are normal, except serum potassium is 7.4. Other lab tests are within normal limits. What is the most likely cause?
Hyperkalemic periodic paralysis. Hyperkalemic paralysis.
Okay. What is the cause of hyperkalemia is the question. You mean it is hyperkalemic periodic paralysis?
Hyperkalemic paralysis.
All right, that's not the right answer.
Hyperkalemic paralysis.
No, hyperkalemic paralysis. The question is what is the cause of hyperkalemia?
Drug induced.
Next you want to try? It is hypokalemia with paralysis. All right. What is the cause of hyperkalemia? D. Team D.
RTA,
Louder.
renal tubular acidosis.
Acidosis. No, that's not the answer.
Tumor lysis, spontaneous tumor lysis syndrome.
No, that's not the answer. Possible, but that's not the answer. F. A.
Drug-induced tumor lysis.
Drug induced. Which drug?
Thalidomide, sir.
Okay, I think you guessed it, but then that is the answer. Thalidomide produces hyperkalemia. I am sure most of you would have seen this also, especially if the renal function is deranged. Right, so this is thalidomide-induced hyperkalemia presenting as paralysis, and you don't call it periodic paralysis also. It is hyperkalemia paralysis, but not periodic paralysis, but it is thalidomide producing hyperkalemia. Okay, we'll go on to the next question. Question number 4, Team D. 52-year-old man, evaluation of proteinuria. Proteinuria is 2.4 gram. Non-myeloablative bone marrow transplant done 6 years ago. BP and serum complement, blood pressure is normal, no normotensive. Complement levels are normal, ANA and K are negative, anti-platelet receptor antibody is negative. What is the likely cause for his proteinuria?
Radiation nephropathy.
No, sorry.
Paraneoplastic membranous nephropathy
Paraneoplastic manifestation?
of membranous nephropathy, possibly THSD or NEL1 related.
Oh, okay. So one you are telling it is, the histology is membranous.
Yeah, secondary membrane.
Okay, membranous, right?
Membranous nephropathy.
Okay. What is the cause of membranous nephropathy?
He received a transplantation. He has received immunosuppressive drugs, so possibly drug related.
Drug related. Right, anyway, it was not intended as a two-answer question. It was not intended as a two-answer question. Right. So, the question is regarding histology, so they have answered it right. Right. You have some question? Louder. Fact 1 related. Okay, all right. And why is it fact 1 related? Okay, all right. Fine. Anyway, so this is membranous. This is well described. There are multiple studies also where usually platelet receptor antibodies will be negative, and this is a form of renal limited GVHD. Right. That's what I think you meant. But the question was intended, what is the histology, that they have answered, so they will get the mark. It is half, right? It went to Team D, and it was the Team E who answered it, and they will get 10 marks.
It's the last question.
Next question, question 5, Team E. 18-year-old man under evaluation for nephrotic syndrome due to minimal change disease. BP is 130/80. He is on 1 milligram per kg prednisolone. He is on Lasix and Ramipril. He still has significant edema. Creatinine is normal, 0.7. Proteinuria is still 6 gram. He is on salt-restricted diet. Proteinuria has decreased from 9 to 6. His edema has not improved. The patient is most likely to benefit from the addition of which diuretic? all diuretics is likely to be beneficial, but theoretically, which is likely to benefit him most?
Thiazide like diuretics. Thiazide like diuretics, like metolazone.
Sorry. Next.
Distal tubule blocking, possibly
Which is,
thiazide.
you have already answered, so you can't answer twice, no? So team F.
Yes, mineralocorticoid receptor blockage.
Right. Sorry, that is wrong. Now the person has to, if anybody answers, they'll have to say the reason also. Team A. Because we are running out of diuretic options, right? He is likely to benefit maximum from which diuretic? And the reason?
Sir, distal blockades, sir, like chlorthalidone, metolazone.
Metolazone. Wrong. Sorry. No, I'm not to say wrong, but that is not the intended answer. Sorry.
Sequential blockade with
Sequential blockade, but that is not a specific diuretic, no? C.
Sir, metolazone we can use for a
Okay, so that two people have already answered, right? This
SGLT2 inhibitors.
SGLT2 inhibitors, sorry, no. So if you look at the answer is amiloride. Theoretically, because proteinuria works through the ENaC channel, right? So we are trying to specify. So I'm telling theoretically. Practically we use metolazone, but this is quiz, right? I would say you are all right, but then quiz it is wrong. Sorry, right? So nobody gets the mark. I should have asked the audience, I think. Next time we'll do that. So last question of this round, team F. 46-year-old lady, cirrhosis, hepatitis C infection, ascites, furosemide 80 milligrams, spironolactone, albumin is 2.4. What is the expected change in the volume of distribution of furosemide? Will there be any change? And if so, what is the change? Volume of distribution.
The volume of distribution change, the volume of distribution will increase.
Okay, all right, you are correct. Can you tell the reason also? You have got the full marks. Why it is increased?
Furosemide is a protein-bound drug. So patient have hypoalbuminemia, there is a more free drug is available. So there is
Okay,
an
absolutely right. So no explanation needed for that. It was a very simple question. So fine. So we come to the end of the second round. We will have another question for the audience. It is recommended that Septran prophylaxis be extended for an year. Usually we give it for 6 months, but it is supposed to be extended for an year while using which of the following immunosuppressive agent? Anybody can answer. You can raise. ATG. No. Belata said already answered. No. The question is, why is Septran given routinely? It is for PJP prophylaxis. Which of these drug is historically reported to high incidence of pneumocystis pneumonia? Sirolimus. So the answer is sirolimus. We are not using sirolimus these days, so people have forgotten, I think. All right. So we'll come back to round 3. This will again start with team A. Right. 12-year-old girl, nephrotic syndrome, started on prednisolone, good response in 9 weeks. She was tapered off. After 2 years of remission, she presents with edema. Protein is 6.5 gram, proteinuria is 6.5 gram. Her kidney function is normal. We know it is relapse. But what additional test in urine can you order which will support the diagnosis of nephrotic syndrome relapse?
Urinary chemokine CXCR3.
Sorry, that is not the answer. Team B?
Urine angiopoietin 4.
No. C? Team C? Team D?
Urine CD80.
Okay, all right, so that is the right answer. So CD8 is a transmembrane protein which is described in children, so that is why you might have noticed the age. This is minimal change in child, right, not an adult. So this is very specific, and this is supposed to be urinary marker for nephrotic syndrome relapse, right? So they get the half marks, 10 marks, A, B, C, D, right, your team D. Good, that was good one. So we'll go to the next question. Question number 2, team B. 25-year-old man, 3+ proteinuria on dipstick. He had fever and he was found to have 3+ proteinuria. Fever subsided, 3 months later he still have proteinuria. He has normal blood pressure. He never had edema. BP is 110/70. Creatinine is 1 milligram. Albumin is 4.2. Biopsy was done. 12 glomeruli, 2 are showing segmental sclerosis. Glomeruli otherwise unremarkable. No interstitial fibrosis, tubular atrophy, nothing significant. No immunoglobulin, C3, C4 light chains are negative. What is your diagnosis based on the available data, and what additional test evaluation would you consider?
FSGS?
FSGS is not a complete diagnosis. FSGS is there in the biopsy itself. No? What is your diagnosis for FSGS? Anyway, your time is up. Sorry. FSGS is there in the histology, you know, that when you read, you know the answer. The question is beyond that. Team C?
Secondary FSGS.
Secondary FSGS, okay, all right, okay, fine. What additional test evaluation would you consider doing?
Electron microscopy.
By the way, why do you think it is, wait a minute, okay. Hey. You wanted to, you were telling something, or you have passed? Time is up, right? Okay, all right, I think I interrupted you, but then he's not giving the answer. You can try. D, team D.
Electron microscopy.
Electron
For
microscopy.
percentage of
Okay, all right. Okay, so that is a, I would accept it as the correct answer, but there are more than one option there. So what is the reason? This is secondary FSGS. This is well known. So this is a nephrotic range proteinuria without nephrotic syndrome. This is, if you look at clinically, we know that this thing is there, and that is not where, when somebody comes in nephrotic range proteinuria, this person didn't have any edema, albumin is normal, so there are no nephrotic syndrome, but nephrotic range proteinuria, and this is from the KD group current GN guidelines. That also clearly depicts the clinical approach. You have to look at, in FSGS, whether the patient is having nephrotic syndrome or not. If somebody comes proteinuria, you do biopsy, you find FSGS, and you don't find nephrotic syndrome, then the clinical approach is completely different, where you will consider secondary FSGS. You will evaluate for the causes including viral, low nephron mass. One way to differentiate is, one is albumin, other by food process effacement, which you will find on EM, right? Or this will also be grounds to do genetic testing on these patients, because the most common abnormality described in this situation is collagen 5 mutations, in the sense Alport syndrome, right? So, okay, all right. So I think secondary FSGS was told by team C.
Sir, actually we have said the answer.
You?
We have answered that question.
You have answered the question.
Actually, it was the
There are
third
two
one.
parts of the question.
Sir, but
No, see, you answered, you didn't tell FSGS, they said secondary FSGS, right?
But it
And
was-
the other half is answered by you.
It was the turn actually. So,
I didn't understand.
It was our turn, sir.
Yeah,
It was our turn to answer, but they actually answered.
No, but you didn't answer, no? That's why it went to them. We waited for you to answer.
Before timing up, they had
sir,
answered.
before time actually we answered that.
Okay, all right. So that brings it. So we will cancel that round and nobody get marks. Right. So who had answered secondary FSGS? I think you had answered secondary. You had answered secondary FSGS. I think we will not give marks to anyone. We will leave that. I think that's fair enough. So don't be over enthusiastic. Okay, right? It's okay, but we are not going to punish anyone. But then let us not confuse you are causing confusion for the quiz master. Right. Okay. So we'll go on to the next question. So no marks for anyone in this round. Question number 3, team C. 54-year-old lady, headache, BP is 180/100, physical examination is normal except for some edema, urine analysis is 3+ proteinuria, and RBC costs are there, creatinine is 2.8. She is referred to nephrologist, biopsy showing mesangial cell proliferation with lobar pattern, Congo red is negative, randomly arranged fibrils ranging 15 to 30 nanometer throughout the glomerulus, IF, sludgy, IgG and C3, light chains, no restriction. So what is the likely diagnosis and what treatment will you advise?
It's MPGN pattern.
Diagnosis, MPGN is a pattern, no, it is not a, it is histological pattern. And I am not sure why you are, anyway, go ahead.
Light chain associated with
Louder.
LCCD, light chain deposition.
Okay, sorry, that's not the answer. Team D.
Fibrillary glomerulonephritis.
Okay, very good. Very good, you are correct. So second is, what treatment would you consider in this patient and why?
And clonal therapy,
All right, that is wrong. We will pass the second half of the question to next team. Team E, do you have?
Fibrillary glomerulonephritis.
No, that is okay. That they get the mark. You won't get the marks for that. Treatment of fibrillary GN is what the question is. How will you treat fibrillary GN?
Steroids.
All right. This patient has renal failure and all, no? Okay, you are not completely wrong, but let us, team F.
At present, steroids we will give, and after that, ACE inhibitors, ARB.
Okay, all right. You will. Sorry about that. You will pass the question to the next team. Team A.
Rituximab,
Rituximab. Okay. Along
along with the AC inhibitors.
with AC inhibitors. All right. I think we'll stop there. Okay. So this is fibrillary GN based on the fibrillary size, right? You differentiate based on this size. So this is fibrillary GN, and what is associated with monoclonal gammopathy is not really fibrillary GN, but immunotactoid. This is not immunotactoid. So by default, you can't assume that this is monoclonal related, and you can't give treatment accordingly. This is fibrillary GN, and usually the treatment consists of steroids plus cyclophosphamide or rituximab, depending upon how they behave. Right. So first half fibrillary GN. Yeah. Now, whose question was that? Okay. So the fibrillary GN was answered by team D. Right. So
Steroids.
no, wait a minute. There are two halves. Okay. So they answered the first half. So that is 10 marks. They will get 5 marks. And the second half went on till team A. Right. Team A gets 5 marks. You didn't answer. Sorry. You didn't answer that.
Sir,
Sir,
steroids,
instead
please take
steroids.
steroids.
That is not, steroid alone is not enough is what the point is. This patient needs steroid plus something else. Okay. So that is the point. That is the intended answer. Sorry, I am not saying that you are wrong. Again. Okay. So we are asking for intended answer what the quizmaster intended. Right. I won't say that you are wrong. So without wasting time, we'll go to the next question. Team D. Question number 4, team D. 45-year-old lady, CKD, diabetes, hypertension, pulmonary tuberculosis. She is on rifampicin, INH, ethambutol, pyrazinamide. She has come with hypertensive emergency. She had well-controlled BP earlier, single antihypertensive agent. There was no evidence of ischemic heart disease. Her renal function has not worsened. She is compliant with medicines, and she reported no dietary indiscretions. What will be the most appropriate next step? Team D.
take the
Sorry, the question goes to next team. Team E.
IV labetalol or NTG for accelerated hypertension management.
Okay. No, what is the management plan? I'm not talking about the emergency management plan. You will control the BP and then you will do what? Why is she having
Rifampicin causing drug interaction.
rifampicin causing the induction? Okay, so how will you manage that?
See, we will give a rifampicin.
Modified ATT containing
Okay,
levofloxacin or
Rifabutin or.
Okay, so your answer, so what you are saying, because the question is on the management. You are telling that you will modify the ATT for this patient, right? And it is correct, right? Okay, that is the wrong answer. Next team.
So we have to check for drug interactions. So we have to adjust the antihypertensive dose because rifampicin may be enzyme inducer.
Okay, so that is the right answer. In the sense, this is a well-known phenomenon, right? I'm sure all of us have seen. There is a study from AIMS which have looked at the drug levels also, therapeutic drug level monitoring, which have shown significant reduction in many drugs, not only antihypertensive. That study was specifically on antihypertensives. Right, so this is from rifampicin inducing metabolism of antihypertensives, and the treatment is not to change the ATT but to increase the antihypertensive dose. Right, so pause question, so they will get 10 marks. Question 5, Team E. Team E, you are ready, right? 42-year-old lady, long-standing diabetes, eGFR is 40 ml, hematuria, chronic flank pain. She had frequent UTI with E. coli, episodes of decreased urine output, secondary to urinary tract obstruction in the past. Patient is not appearing ill at present and has no dysuria. Kidney biopsy shows macrophages, abundant, foamy, multinucleated giant cells with owl-eye appearance and positive PIS staining. What is the likely diagnosis?
Malakoplakia, Michaelis-Cutman bodies.
Okay, all right. So that is the right answer. The appearance is quite typical, right? This close differential diagnosis is endogranulomatous pyelonephritis, but the histology gives the diagnosis here because you are seeing the very typical Michaelis-Cutman bodies which you would have read in Robbins back in the MBBS days. All right, so we'll go to the last question of this round. Question number 6, Team F. 16-year-old girl, muscle cramps, weakness of lower limbs, found to have severe hypokalemia, improved with IV potassium. She had history of nocturnal enuresis till about 13 years of age. After that also, enuresis is not there, but she has nocturia. BP is 106/68, creatinine is normal, sodium 140, potassium, hypokalemia is there, magnesium is 1.6, pH is 7.46, bicarb is 28, pH is 7. Spot potassium is 36, urinary 24 potassium is 93, calcium creatinine ratio is 0.3. You will get some time, don't worry. What will be the most appropriate next step? The question is not the diagnosis. Okay, you can tell the diagnosis, no marks for that. What is the next appropriate test for her? Because the diagnosis is evident.
So, what is genetic testing?
Louder.
Genetic testing next.
Genetic testing for what?
Barters.
Barters. That is
interstitial disorders, so we have to do genetic testing to rule out.
what? Genetic testing for what? Genetic testing is a very non-specific answer, no?
What?
You don't think any other test is indicated?
Tubulopathy is there, sir.
Tubulopathy. All right, so we'll come back to that. We'll go to the next team. You will get some credit for this. Okay.
Sir, the diagnosis is a Gentleman syndrome, sir. I would
Okay.
like to order genetic testing to confirm Gentleman.
Okay,
Sir.
what?
Ge- uh,
Confirm what?
Gene mutation, sir.
Of course, genetic testing is done to do
Yes,
that.
Sodium chloride transporter mutation, sir.
Okay, all right. So this is Gentleman syndrome. This is not Barter's, right? This is not Barter's. Okay, so the diagnosis, basic diagnosis is wrong. So genetic testing is a shotgun answer to everything you get, right? So this is Gentleman syndrome, and this is not, there is no hypertension, so aldosterone and all will not play any role, right? So the thing to, the clinical diagnosis is very evident. When you have Gentleman syndrome in a young person, the other DD is what? Diuretic induced. But that is not usual in our culture, it is not common, and in children it is not common. That is the significant history from nocturia, nocturnal enuresis from childhood. Child cannot be abusing diuretics, right? So the answer is Gentleman syndrome and specific genetic testing, right? Okay, so I don't think you deserve the credit for answering this question, team number F, right? Because you made a diagnosis of Bartter syndrome, so it will be considered a past question to team A. Team A will get 10 marks, half of it. So we are at the end of three rounds are over. All right, so we can calculate the marks while we finish the open house question. Mechanism of action of sibeprenlimab. Options are there, so I'm sure people would have heard about it. All right, so people have answered already. Okay, many people have answered. So the answer is C. No, number 3. Right, so can we have the scores, please? You have a mic there. Huh? You can come over here.
At the end of the 3 rounds, Team C yet to open the account, Team B with 25 points.
Can you tell in ABCD that order itself?
Team A is 40 points.
40.
Team B 25 points. Team C 0 points. Team D 45 points. Team E 30 points. And Team F 30 points.
Okay, all right. So it's going well. So again, to the quiz, I have put long questions because I think it should be a learning experience rather than asking recollection questions. So bear with me for that. I'm sorry. Okay. So we'll go on to the next round. So this round will start from the other end. So it will go from F to A. Right. So this is question number 1 to team F. 48-year-old male, kidney transplant, mother was the donor, thymoglobulin induction, TAC, MMF, ranitidine. He had acute rejection. He had graft dysfunction with cytopenias, elevated transaminases after 6 months. CMV DNA is 22,000 copies. MMF was stopped, started on valganciclovir, therapeutic dose, and after 2 weeks, the CMV DNA titer is 49. What are the antiviral agents which may be useful?
Mirabavir.
Okay.
Letiram.
Okay, all right. So what is the reason? Anyway, I think you get credit for that, so you are right.
Oscarnet.
Because you know where the mutations are, right? Nothing else will work. All right, so we'll go on to the next question. Team E. This is a CMV resistance, and this is something we see. This is our own case for your information. This is not being unheard of. That too, one of our student. So team E is in question number 2. 34-year-old lady, SRD on regular dialysis for 4 years. Plan for transplant. Mother is the donor. Transplant is scheduled at 4 weeks. On pre-op evaluation, when she is being scheduled for transplant, found to have HCV infection and HCV RNA titers are 1 million copies. Showed ultrasound fibroscan is showing compensated cirrhosis without portal hypertension. So what is the most appropriate step in her management?
Start on antiviral therapy, directly acting antiviral therapy.
Okay, all right. So you'll start on antiviral therapy, and then once the treatment is completed, you will. She's eligible for transplant. What do you think?
She doesn't have any portal
hypertension. Okay, all right, fine. So fine. Okay, thank you. The answer is wrong, so we'll go to the next team.
She can go for a combined liver kidney transplantation.
Okay, so your answer is, your plan is combined liver kidney transplant. That is wrong. So next team.
We can proceed with transplant, sir. We have to start with antiviral and we can proceed with the transplant.
Okay, so you will start with antivirals now and then do the transplant. Okay, that is wrong.
We will treat with direct acting antiviral agents,
Okay.
and we will monitor for a sustained viral response after 6 months. If it is sustained, we can go with.
Okay, that is wrong. Sorry.
We'll go ahead with the kidney transplant and we'll start the antiviral treatment after transplant, sir.
All right, so that is the right answer. If you look at the KDIGO hepatitis A guidelines, this is what exactly it says. The patient is not having evidence of portal hypertension and all, even though there is some evidence, and this is a planned living donor transplant. So if you look at the algorithm, it says you go ahead with the transplant, patient is not having any liver decompensation or anything, and it is okay to start antiviral therapy after you do the transplant. You are not supposed to delay the transplant for that reason. So team A gets 10 marks. We'll go on to the next question. This is to team D. Team D, right? 63-year-old male, ESRD on CAPD for 2 years. He has 2 episodes of peritonitis. He has got IP antibiotics. He has history of hyperglycemia despite insulin therapy. He had lower urinary tract symptoms and was found to have enlarged prostate. He is being planned for TURP. The urologist is asking you what antibiotic prophylaxis to be given. What is your recommendation? CAPD going for TURP.
This antibiotic prophylaxis not required.
Not required, yeah, that is the right answer. If you look at the ISPD recommendation 2022, it is recommending antibiotic prophylaxis only for scopies and gynecological procedures. TURP and all will not require. So they get the full marks. Team D, right? Question number 4, team C. 32-year-old female, ADPKD, came to the emergency, fever, abdominal pain, nausea, vomiting, no history of dysuria, hematuria, neutrophilic leukocytosis, CRP is elevated. She underwent ultrasound and CT imaging, which didn't show any obvious source of infection in the kidney. Kidneys are looking okay. She had liver cysts with some doubtful internal echoes. What is the imaging modality of choice for further evaluation?
CT angio.
Louder.
CT angio.
Sorry, that is not the recommended investigation. Next.
WBC tag PET.
WBC tag?
PET scan.
PET CT. Okay, all right. I think we'll stop at that. So, why are you saying that? Is there a recommendation? It is not. He wants to. Will not. Can you explain that? WBC tag?
Very much specific to localize.
It will localize. Okay, that's not exactly the answer which is expected.
Sir, to distinguish whether the infection is coming from the liver or kidney, like we have to do a PET CT, sir.
All right. So, in fact, that is the correct answer. You have to do an FDG PET. That is what the KDIGO recommends, right? If you look at the KDIGO guidelines, if the patient comes with suspected liver cyst, this is actually liver cyst. What is recommended is an 18 FDG PET CT, right? Okay. So, this is a paused answer. Team A will get credit for that. This is next is question number 5. Team B. 6-year-old boy, situs inversus, found to have multiple renal cysts on imaging. Family screening was negative. What is his likely diagnosis?
ADT KD.
Sorry, that's not the answer.
Sir, senior locum, sir.
Senior locum has situs inversus.
Sir.
That's not the intended answer, sorry. It will not come, it will come in extra-renal manifestation. Your approach is right in that what we are looking at is cyst with extra-renal manifestations. This will go to team F. No?
Jival syndrome. Jival syndrome.
Jival.
Jival syndrome.
I'm not getting that name. Joubert syndrome. Or?
Not Joubert.
Which one?
Jival syndrome.
What is that?
Jival.
What is that?
Thoracic dextrocardia with nephronophthisis.
No, that's not the answer. Next team.
Cart-Jenner syndrome. Cart-Jenner.
No. We started with you, right? Okay, we'll come back. Audience. HNF, no. No, sir, no. Okay, so we can look at this. This is from a review on, there is a nice review on cystic disease in children and adults, which came in seminars in nephrology recently. So if you look at it, there are multiple cysts, family screening is positive, and the patient is having extra renal manifestation. So this will come in this group of conditions, and it is NPHP which is having situs inversus in that. Right, so it is nephronophthisis is the correct answer, even though it will come, the approach is right, at least for the team A. But I won't give you marks for that, sorry. All right, so we'll go to the next sixth question, team A. 32-year-old man found to have BP of 240/120. He was well with chest comfort and headache. He had no significant illness in the past. There is no family history of hypertension. He had symptoms suggestive of intermittent claudication involving the right lower limb. And the right femoral artery pulse was found to be feebler on the left side. There was evidence of grade 4 hypertensive retinopathy in the right eye, not in the left eye. He had prominent LVH on echocardiogram. The kidney size is 11 on the left, 7.5 on the right. Doppler USG is suggestive of renal artery stenosis. The question is not what is the cause of renal artery stenosis, but because the diagnosis is again very evident, what investigation will be most useful in diagnosis and management? So you have to give attention to that, diagnosis and management.
Sir, it's basically a renovascular disease causing renal artery stenosis, secondary to probably a Takayasu disease. And I would like to evaluate the renal artery stenosis with CT angio and stent the renal arteries, sir.
You have renal artery stenosis already proven on Doppler, right? You already have. So you'll pass the question.
So CT renal angio followed to look for what is the main cause of renal artery stenosis.
All right, so that is the wrong answer.
So I will do a renal angiogram with a balloon angioplasty.
Sir, it is basically Takayasu disease. So vasculitis.
Yeah. No, I am not asking. The question is not about the diagnosis, right? So your time is up anyway. Your time is up.
And
Next team. Your time is up. Don't let us not confuse.
We'll directly go for percutaneous transluminal angiogram and with stenting.
Okay. Which investigation will you? The question is on the investigation you will order.
You can do a perfusion imaging, bold MRI to know
Okay. Sorry. That's not the answer.
DSA can we go, sir? Digital subtraction angiography.
That is not the intended answer. Okay. So usually what we'll do, so the renal artery stenosis is very evident. This is Takayasu because you are doing asymmetry in the lower limbs, pulse is there, asymmetry of retinopathy you are finding, right? Claudication is there. No, it's up. Your turn didn't come. Huh? Your turn didn't come. Okay, fine. You can try.
Conventional angiogram followed by PET-guided biopsy of arterial biopsy.
No, that is not the answer. Sorry. Okay. Your quizmaster is having a different answer. Sorry about that. Okay. So here basically the renal artery stenosis is confirmed. So there is, the investigation is not intended to confirm renal artery stenosis, but this is Takayasu. For management, you like to know whether this is an active disease or not also, right? Which investigation will help you? No, sir. No. Actually, what is recommended in this situation, if you look at also, this is Takayasu, and this captoprolinogram and all is no longer recommended. Biopsy is not possible and not going to help. Split GFR also is not going to help because you already know that. But PET scan, this is actually our own patient. Okay, PET scan will tell you because renal artery is confirmed. My question is on investigation to help diagnosis and management, right? So PET scan will show you active disease in the aorta and the aortic wall. So that will help you to decide on immunosuppression as well, right? Okay, we'll go to end of fourth round. We'll go to open house question. Easy question. Which condition among the following do not need an electron microscopy for a definitive diagnosis? I am not telling confirmed 100% diagnosis. Right, so Dr. Satish is very quick to answer. It is amyloid because you don't really need EM to make that diagnosis. So that's why I use the term definitive diagnosis. All right, anyway, so we'll go on to the next round again, starting with team F. First question. So this is, you have to, I will show you an image and you have to tell us what it is, right? We have to tell what the image is showing. Right, okay.
Mars.
No, sorry.
Biological artificial kidney, BAK.
Bioimplantable
Bioimplantable artificial kidney system.
All right, okay. Bioimplantable artificial kidney.
Biological artificial kidney system.
Okay, I think I will give you. Why are you saying that? What told you that is the?
Sir, there is a hemofiltration going on, and the spendylicite is attached to a silicone wafer to which the proximal tubular epithelial cells are attached.
Okay, all right. So the answer is bioartificial kidney. Bioartificial kidney, which is very well known, right? So you have additional component of biological component where there is additional toxin removal happening. Okay, this is the schematic representation of a bioartificial kidney. There was a recent review in Nature Reviews. You can refer to that. We'll go on to the next question. Again related to extracorporeal therapy, team E. Identify the dialyzer represented by the graph with the red marker. The graphs represent dialyzers.
High retention onset dialysis.
High retention dialyzer. Okay, that is the wrong answer. So we'll go.
High flux.
No, that is the wrong answer. So
high cutoff dialysis.
Sorry. Next, if you have answered and your time is, you can't answer again. You have only one attempt. Team C. Your time is up, sorry. Team B. Louder.
Low efficiency.
No, sorry. No, if you look at it, audience, someone, if you look at it, the clue is, okay, they have, sorry. Team F, I'm sorry. You have to get the, what is that?
Pass.
No, they passed it.
High cutoff.
Sorry. That's it, right? We finished. Audience, anyone? Hemodiafiltration. Yes, Dr. Satish is usually correct as usual. Okay, this is This is, see, if you look at the beta 2 microglobulin, it is ending here. No? So the first one must be what? Low flux, right? And the second one will be what? Because there is albumin going in the green one. So here is something which is having good clearance of beta 2 microglobulin and all, but albumin is not that much. All right. So
sir, I have one doubt. Sir, median cutoff dialysis are now being labeled as high retention onset dialysis according to a recent
I'm not aware of that, sorry. I don't know. I'm aware of what I intended is the expanded hemodialysis, what is called the expanded hemodialysis, where this Terra Nova has come to the market in India. So this is a different one. This is not the retention dialysis which I am aware of. This is what I am referring to. Yeah, but sorry, I'm not going to mark for that. So this is what is called the expanded hemodialysis with what is called the medium cutoff dialyzer, where you will see the protein leaking is less than that of a albumin leaking dialyzer, right? So this is what we call the expanded hemodialysis, where you have higher permeability for middle molecules, but there is not loss of albumin, right? Okay. So with that we go to the question number 3, which will go to team D.
It's a PET test for finding out the transporter status.
Yeah, this is PET. This is PET. What is the finding and what could be the reason?
High average transporter in. So that dot high transporters in this graph.
High transporter in that.
And there it is low transporter.
Okay, all right. So that is the right answer. Okay, why? What is the reason?
Because that patient might be having a very high glucose in the beginning.
Okay, so I'll give you full marks for that. So this is not an easy question also. So there is a discrepancy in the glucose versus creatinine, right? The ratio. So one is showing high transporter, one is showing low transporter, and this is classically described in patients having severe hyperglycemia where the gradient is not there for glucose. And this, the ideal correct thing to do is to correct the glycemic status and then repeat, and usually it will show something similar to the creatinine D/P ratio, right? So they get full marks for that. Question 4, team C. What is this image showing? Team B?
Recirculation.
Okay, that is not the correct answer. The time is up.
Cardiopulmonary recirculation.
So it is cardiopulmonary recirculation. It's not recirculation. It is cardiopulmonary recirculation, right? So you can see that if you look at it, how the concentration is changing, right? And there is a dialyzer also. There is a extracorporeal circuit as well as the regular circuit, the regular circulation happening. All right. So this is the cardiopulmonary recirculation depicted in image. Question number 5 to team B. What is this composed of? Sorry about the grammar mistake. What is this composed of? These are all the same. Substance is the same.
Cystine calculus.
Cystine, sorry, that is wrong.
Uric acid crystals.
Yeah. This is uric acid, right? Because it is colorful because it is polarized. It is under the polarized light. So this is uric acid. So they get 10 marks. Team A gets 10 marks. Last question of this round, team A. What is this procedure?
This is saline dilution method to detect the recirculation, excess blood flow and recirculation.
All right, so I'll give you credit for that. This is measuring access flow by dilution, whatever dilution you use. It may be saline or it may be something else, right? So this is technique used where you artificially you have reversed the axis. If you see, this is the venous one, this is the proximal one. So you are inducing recirculation and measuring the access flow. Good, that was a good one. It was supposed to be a tough question. So open house question. What is the specificity of anti-PLA2 receptor antibody in membranous nephropathy? No choice for that. What is the specificity? 100%, any 95%? Nearest answer will get there.
100%.
It is 99%. So I think Satish will get the maximum is 97 to 99%, right? So it has high specificity for PLA2 receptor antibody. So if you find PLA2 receptor antibody, you are certain that membranous nephropathy is going to be there. So specificity is very, very high. Okay, so we will go to round 6. Before that, can we have the scores again before you go to the last round?
Team A is at score of 100. Team B is at 25 points. Team C is 0. Team D is 85. And Team E is at 40. And Team F is at 50 points.
Okay, now one is having same marks as of now. All right. We may not have to go into tiebreaker, I suppose. So we'll start with the last round. Again, we'll start with Team F. So, which IV fluid is this? You have given 1 liter of this fluid IV, and then you are seeing this. ECF is 333, ICF is 666. Administration of which IV fluid will result in this distribution?
Dextrose solution.
Okay, all right. So this is 5% dextrose. No explanation needed, right? Okay. So they get full marks for that. Question number 2, Team E. The duty nurse informs you that an adult patient undergoing intermittent acute peritoneal dialysis developed hypokalemia, and she added 1.5 ml of potassium chloride to the PD fluid bottle before starting subsequent exchanges. What is the concentration of potassium in the PD fluid? You have to be actually doing acute PD to know this. Sorry. Team D.
Like 2 milliequivalents potassium, like 10 ml is
2 milliequivalents.
20 milliequivalents.
No, it's okay. 2 milligram is wrong. 2 milliequivalents is wrong.
3 milliequivalents, sir.
3 milli. Why do you say it is 3? Why is it 3?
10 ml, 1 ml contains 10 milliequivalent. Oh, sorry.
You guessed the answer, but still I think I'll give you credit for that. The answer is 3 because it is simple. If you have if you have done PD at any point of time, you will know that 1 ml is 2 milliequivalent. So you have added 1.5, and you also need to know that acute PD bottles are 1 liter bags, not the 2 liter PD bags. So if you add 3 milliequivalent to 1 liter, it is 3 milliequivalent per liter. It is simple. So intended as a simple question, but I will give half marks to them, 10 marks, right? So we'll go to the next question. So this is 3 milliequivalent. Next question is Team D. Transplant recipient, immunosuppression, TAC, MMF, fever, cough, breathlessness, 6 months after transplant. He had biopsy, proven TCMR 6 weeks after transplant, was treated with IV methylprednisolone. The rejection resolved. Current hospitalization, he was noticed to have subcutaneous hard nodules, small cutaneous abscesses on his legs and scalp. CT chest showed consolidation, multiple high dense lesions throughout the lungs. Hospital he developed seizures. MRI showed well-defined ring enhancing lesions, frontal and cortical regions. Gram positive, catalyzed positive, rod-shaped bacteria on FNAC. The question is not a diagnosis again. What is the most appropriate treatment? The diagnosis again is fairly evident.
Nocardiosis treated with Septran and Doxy plus and Septran combined.
Okay, so question is not about the diagnosis. So this is nocardiosis. Treatment what you are suggesting is Septran.
And we should combine it with doxycycline.
Septran and doxycycline. Not entirely correct. Okay. We'll go to the next.
And prolonged.
We'll go to the next team. C.
Rifampicin with meropenem.
Rifampicin with meropenem. Not what IDSA recommends. So your answer is wrong.
Piptas.
Piperacillin tazobactam. That's not correct.
Carbapenem.
Carbapenem, okay, carbapenem, but that is not correct. That is not the correct answer. I'm not saying that carbapenem is not useful. The question is, what is the appropriate treatment, right?
Reduction of immunosuppressant.
Septran plus IV steroids
Reduction
for
of
blood pressure.
No, their turn is over. So you are answering now.
Septran plus IV steroids for reduction
IV
of pain.
steroids, not really. That is not the intended answer. We started with whom? So audience, Dr. Satish. This is disseminated nocardia. You are having lung, skin, brain, seizures, right? So actually all the drugs named are actually used. Septran, meropenem, steroids may be indicated. But what is the recommendation to treat? What is the antimicrobial choice? Disseminated is treated with combination of a carbapenem plus Septran or amikacin. Right, it is not doxycycline. You won't get credit for that. Okay.
10 marks.
So the quiz master takes the mark. So this is the IDSA recommendation. So this is the case scenario is described to give you not only diagnosis of nocardia. This is disseminated nocardia. It's because two drugs, and that too either carbapenem plus another one which is amikacin or aminoglycoside or Septran. Right. We'll go to the next question, question number 4, team C. 58-year-old man, regular hemodialysis. He developed a syndrome of nausea, vomiting, weakness, flushing, labile blood pressures. Which contaminant? This is to test whether you are reading textbooks.
Nitrates.
No, that's not a right answer. Team B.
Chloramine.
No, you are wrong.
Ethylene oxide. Sterilization, ethylene dioxide.
No, sorry, that's not the right answer.
Formalin reaction. Formalin reaction.
I didn't get that.
Formalin reaction.
Formalin, no, sorry.
Aluminium.
Aluminium.
Hard water syndrome.
Okay, so this is aluminium. Okay, this is there in Dogridas, so even we might not see it now. This is aluminium toxicity happening. We'll go to question number 5, team B. 24-year-old man had trauma, underwent neurosurgical procedure. He was on levetiracetam for his seizures and piperacillin tazobactam. He is on 3% saline and other supportive measures. His creatinine was 1 at admission and it is now 0.5 and a nephrology consultation was sought. What is your renal diagnosis? Renal diagnosis, and what would be your management advice? Sorry, that's the wrong answer. We'll go to the next team, Team A.
Sir, it's interaction of peptides with creatinine excretion.
What is your renal diagnosis?
Sir, I'm thinking of interaction of peptides with creatinine excretion, sir.
You don't have a diagnosis,
Sir,
so you can't treat it. If you don't have a diagnosis, you can't treat it.
Normal
Sorry.
renal function.
Sorry.
Sir. Normal renal function.
It is not normal. Sorry. We will have to pass that question. Team F.
Acute kidney injury for
Sorry, that is not correct. Team E. This is an actual consultation we got, so you're not imaginary. Okay, this is our neurosurgeon called me.
Sir, peptidase interaction with creatinine for
Diagnosis,
secretion.
please. Renal diagnosis first. We should not treat without a working diagnosis at least. No, you may not know the diagnosis, but we should know working diagnosis.
Acute kidney injury.
All right, in what sort of acute kidney injury creatinine will go down? We started with B, right? So,
Tazobactam increase in tubular secretion of creatinine.
no, sorry, that's wrong. C. No, we started with B, right? So it's up. Audience, please. What is the name of that diagnosis?
augmented renal clearance.
Ah, exactly. Who said that? Yeah. This is augmented renal clearance. Okay, this is augmented renal clearance, that is the diagnosis, and that usually will result in subtherapeutic. Usually what happens is a rapid drop. So it may not affect people, antibiotics which work with the, what do you say, the Cmax thing, the peak levels. So higher clearances, short half-lives. The treatment is usually, when it is beta-lactam, like this patient was getting, levetiracetam, is to give infusions, right? So this is augmented renal clearance, which if you carefully look at critically ill patients, you will be seeing significant numbers. This was an actual case we had. So question number 6, the last question of the last round. 16-year-old girl referred for kidney transplant, regular twice a week dialysis for 1 year, recurrent renal calculi in the past, bilateral nephrocalcinosis, oxalate level is 90 micromole per liter. She could not afford genetic testing, so she was started on vitamin B6, right? I hope you know the diagnosis now. What will be your HD prescription for her, team A? And at 6 months, her serum oxalate is 45 micromole. Will you advise transplant? Can you ask me one by one?
Sir, I would suggest daily hemodialysis, sir, to enhance oxalate clearance.
What dialysis?
Daily hemodialysis.
Daily hemodialysis, okay.
Yes, sir. And for oxalosis, the treatment of choice, depending on the genetic mutation, depending on the genetic mutation.
Genetic mutation is not done here.
Yes, sir. I will go
this
for
is the patient. This is
simultaneous liver kidney transplant. I will go, sir.
Okay, this patient. So you okay? Anything more about the dialysis you would like to?
Sir.
Okay, fine. It's okay. Your time is up. So for first half is okay. They are telling they will intensify dialysis. Second part is wrong. Will you advise transplant?
So, no sir, first we have to do genetic test, then only we have to do.
Okay, so genetic test is not done, so what you are saying is you will not prefer to transplant, okay? But that is not correct.
Sir, frequent dialysis, that is daily or?
And that first question is over, you won't get any credit for that.
Sir, we can go for combined liver kidney transplant.
Okay, so you advise combined liver and kidney transplant, which is wrong. Team D? You can take louder, otherwise you will lose your time. Louder, don't fit.
We can adjust the dial cell calcium, we can reduce the dial cell calcium so that.
Okay, but what about transplant? That is the question. Will you do transplant is the question. First question is over. HD is over.
Yes, we can proceed with transplantation.
You will do kidney transplant?
Yes.
Okay, why? Why will you do kidney transplant?
Because transplantation has a better outcome.
No, this patient has, what is your diagnosis?
Primary hyperoxaluria.
Okay, alright, hyperoxaluria. You're okay with doing kidney transplant alone?
The combined liver kidney transplantation.
Okay, the answer is correct. So even though I don't think your explanation is right, this is primary hyperoxaluria, whatever you call it, right? Because the clinical diagnosis is clear. But if you look at it, the level has significantly more than 50% reduction has happened. 90 micromole to 40. No. Yeah, 45. So it has come by 50%. Okay, if you are aware, there is a recommendation which has come in recently. If you look at, see, the first part is that you have to intensify dialysis. Intensification can be regular dialysis, but it is advisable that you do high flux dialysis if possible because of the obvious reason. Normal oxalate removal is very limited. Even if you do high flux dialysis, it will barely meet the weekly generation of oxalate. So ideally is to do daily hemofiltration, high flux dialysis for these patients. It may have to be supplemented with PD also. So intensification of dialysis is what is needed. And so intensification to keep plasma levels below 550 to 70, because that is the normal level in people on dialysis without oxalosis, right? So you have to come back to normal. And if you look at the algorithm, it says that if we have done generating okay, but if it responds to vitamin B6, responds to treatment, then you can go ahead with transplant. So that is the reason. Irrespective of the mutation, if your vitamin B6 supplementation works, then you need not go for combined liver and kidney transplant. You can go for isolated kidney transplant. So the first half mark goes to, this was your question, so 10 marks goes to team A and 5 mark goes to A, B, C, D. You marked it correct, right? Can we have the open house question is there, meanwhile you can tabulate the marks. Everybody will know who did dialysis, but who was the person who underwent dialysis? Everybody knows who did dialysis, where it happened, but who underwent first dialysis? Louder. Yeah, audience. No, name of the person or identity of the person. Okay, all right. Okay. Maharaja of Oudh of Bihar was the first patient in CMC. Right, so can we have the scores, please? You can come here also. We have the final scores. We don't have a tie, so we're ending the quiz here. Team C gets 10 marks. Team B gets 25. Team E gets 50. Team F is 70. They are third. Team D is 90. They are second. And Team A is 110. 110. So they are the first. So first is Team A, second is Team D, and third is Team F. Congratulations. Thank you once again for asking me to do the quiz. I don't know whether you enjoyed it. I hope so. I did enjoy preparing the questions. Thank you.
Thank you so much, Sreejith.